Good morning, good afternoon, everyone. Many thanks for the kind introduction. We at 3IE are very pleased to be one of the co-hosts of this conference dedicated to delivering for nutrition in India. Why is it important to talk about nutrition in India? India is facing a malnutrition crisis and the statistics are alarming. The Global Nutrition Report shows how India is doing much worse than comparable developing countries on nutrition indicators like under 5 stunting and wasting. With more than 45 million children stunted, India accounts for a third of the world's incidence of stunting. More undernourished children live in India than in any other country. In this context, India's Poshan Abhiyan is a step in the right direction, given that there's a lot that India needs to do if it is to reach the Sustainable Development Goal of ending malnutrition by 2030. COVID has only made this challenge more formidable with the disruption of important food supplementation programs and markets and increases in poverty. The task before the policymakers is therefore Herculean and requires effective program implementation. As a community, we have, however, given insufficient attention to understanding the importance of program implementation in achieving good results. Program performance has been measured simply by outreach targets that do not meaningfully capture implementation issues or encourage a conversation around demand and supply side barriers. These barriers may be a significant part of the reason that many programs fail to reach their potential. Implementation research, therefore, is critical if we wish to solve India's malnutrition problem. Implementation research has helped us confirm the fact that simple, single nutrition interventions are unlikely to help us achieve the desired outcomes if there are systemic gaps, for example, in the fields of health and water supply and sanitation. In Uganda and Kenya, for example, 3IE-supported research found that achieving outcomes in iron and folic acid supplementation uptake works best if factors such as health service provision constraints, stockouts, delayed utilization of antenatal care services, information gaps about adequate iron and folic acid supplementation, consumption and potential side effects, community outreach, male involvement, that all of these are addressed and accounted for. But there remain and are many knowledge gaps. What combination of intervention activities or levels of intensity are needed to ensure behavior change? If implementation is successful and desired outcomes are observed, how do we know which intervention activities matter the most? The linkage between implementation and effectiveness is not always known. And these questions are important to consider as policymakers struggle to understand how best to design public policies and programs with limited resources. However, implementation research faces a number of challenges. One area is that the tools and methods needed to carry out this type of work are often less publishable and hence less attractive to researchers. The other problem is that of generalizability. Because interventions are constantly redesigned and repackaged with other activities, it is very difficult to identify the unique and generalizable effects of specific interventions. Instead, we are developing ever longer lists of packages that worked one time in one context. Therefore, researchers have the challenging task of synthesizing this wide body of evidence. Well, with this complex backdrop, we undertook a mapping of the implementation research literature for nutrition interventions in India in partnership with IFPRI. And today, I'm very happy to have my colleagues Stuti Tripathi and Pooja Sengupta present the findings from this study. So over to you, Stuti and Pooja. Thank you.
Good morning, everyone. I'm Stuti Tripathi, and I will be presenting with my colleague and co-author Pooja Sengupta, and we will be sharing findings from our work on mapping implementation research in nutrition. I would first like to begin by thanking the host and co-host for providing us this opportunity to present the study to a really distinguished audience. Implementation research, as we all agree, is critical to understanding program implementation and an important prerequisite, therefore, to improving nutritional outcomes that these programs target. Given this, IFPRI and 3i collaborated in 2018 to create a gap map for implementation research on nutrition-specific interventions in India. Let's spend a moment here to understand what a gap map is. What the gap map basically does is that it consolidates evidence in a particular sector, which in our case is nutrition. This consolidation entails sifting through large volumes of literature to find studies which speak to the population, intervention, and outcomes that fall within the scope of the study. It then visually depicts the stock of evidence to create a gap map. This gap map can then serve as an important tool for policymakers, practitioners, researchers, commissioners of research to set research priorities by pointing people to areas where gap exists in terms of either little or no literature, and therefore more evidence is needed to inform policy and programming. As a first step, we developed an implementation framework for nutrition-specific interventions, which are the focus of this gap map. The interventions included those around food supplementation, fortification, micronutrient supplementation, behavior change counseling, severe acute malnutrition management, delayed cord clamping, weight during pregnancy, and bundled interventions. Our preliminary review of the literature showed that a majority of these interventions are delivered primarily through 4 platforms, namely the ICDS, the National Health Mission, the health system, or the SHGs, and that many factors, in fact, affect the delivery of these interventions. We parsed these out at 3 levels. At the program level, this included indicators like access, targeting, adequacy of resources, the monitoring mechanisms in place, and the cost of delivering the program. We also found that frontline and other health workers' acceptability, knowledge, performance, and other factors to be equally critical in program delivery. The services reach participants either through home visits or at health facilities or both. This range of factors together then have a bearing on the participants' knowledge, acceptability, and feasibility of participating in the program, which then affects their ability to take up the program and thereby has the potential impact on nutritional outcomes. Add to this are then various contextual factors that affect program and FLW performance, and also the beneficiary's ability to participate in the program. The population that we looked at consisted of pregnant and lactating women, mother of children below 2 years of age, and children below 2 years of age. We, however, later expanded this category to also include children and mothers of children 0 to 6 years, given that a large number of papers, especially those around ICDS, look at 0 to 6 years age bracket. And therefore, sticking to 0 to 2 years would have meant us losing out on this very important piece of literature. In terms of how we went about developing the map, we first developed the search strings and combed through 13 databases, focusing especially on those that have a public health emphasis. We supplemented this with a manual search of literature on websites of over 35 organizations. Electronic and manual searches together yielded about 24,000 records, which after screening for duplicates and screening title and abstracts and later full text against a well laid out inclusion-exclusion criteria, left us with about 368 papers, which were then included in the gap map, and the findings for which will now be presented by my colleague Pooja. Thank you.
We'll now discuss some of our key findings in detail. We have only included evidence that was published between 2000 and 2018. We plotted the papers by year, and we find that there is an upward trend with an increasing number of papers examining implementation outcomes over the years. As you can see from this figure, while there is an overall steady increase in literature measuring implementation outcomes, the trend is not uniform across the years. Overall, though, it is encouraging to see a fairly steady increase in the literature measuring implementation outcomes. In terms of distribution of papers across states, the evidence is encouraging, with some evidence across all states. In terms of the magnitude of evidence, Uttar Pradesh, Gujarat, Bihar, and Odisha are the 4 most studied states, though it is hard to tell why that may be the case. States in the Northeast remain neglected, with only 7 papers looking at interventions in this region. Some of the other states where we found comparatively lesser evidence are Himachal Pradesh, Jammu and Kashmir, Telangana, and Kerala. In this figure, we provide a breakdown of the target population for included papers. FLWs and health workers were coded as the target population because their performance has a direct bearing on the quality of program implementation. A total of 175 papers look at FLW level outcomes like coverage, acceptability, knowledge, etc. The evidence also suggests that a primary target population like pregnant and lactating women and children under 2 years of age have been well represented in the literature. Under delivery platforms, we coded for ICDS, National Health Mission, self-help group platforms, healthcare systems, and other platforms. The healthcare system code is used for papers that study intervention delivery in a hospital setting or a primary healthcare center and either predate National Health Mission or do not make any reference to it. We found that 66% of the included papers examine ICDS, making it the most studied delivery platform, followed by healthcare systems. Now, given that ICDS is one of the largest nutrition programs in India, reaching out to nearly 20 million pregnant and lactating women and 82 million children, this finding perhaps is not surprising. During the initial phase of screening and coding of literature, one of our concerns was surrounding the lack of description of interventions that the studies examined. A discussion on program design and rollout is an important prerequisite for research that seeks to assess program implementation. We, however, found that 33% of the literature that we included is unclear on the program model and delivery, especially for papers that look at flagship programs like ICDS and NHM. Papers are coded as intervention details unclear in our study when, for example, the paper does not detail activities performed by Anganwadi workers but measures implementation outcome indicators such as the number of Anganwadi workers maintaining records or doing home visits. In this slide, we present the evidence available on interventions and implementation outcomes in our study. Among the included interventions, behavior change counseling is the most studied intervention, as depicted in the first figure. Within the counseling interventions, breastfeeding counseling is studied most, followed by growth monitoring and counseling, and then by complementary feeding. Micronutrient supplementation is also a fairly well-studied intervention, and this is primarily driven by the literature on iron and folic acid supplementation, which accounts for 49% of the papers in this category. In bundled interventions, we categorize papers that did not specifically look at the delivery of any one particular intervention, but instead measured, for example, FLW perceptions of their workload, programmatic delays in making payments for services or goods, infrastructure quality of Anganwadi centers, or participants' assessments of service quality. Bundled interventions were coded in 382 such instances. The least studied interventions were management of severe acute malnutrition, delayed cord clamping, and weighing during pregnancy. As indicated in the second figure, implementation outcomes at the participant level are the most frequently studied. We coded for implementation outcomes for a total of 1,624 times, out of which 51% constitute outcomes at the participant level, followed by FLW level outcomes at 26% and program level outcomes at 23%. Participant level outcomes were coded across 5 implementation outcomes of acceptability, coverage, feasibility, knowledge, and uptake. We found coverage and uptake to be the most studied outcomes. Receiving a service was the primary indicator of coverage across interventions. It included factors such as receiving advice or counseling with regard to, for example, breastfeeding, getting enrolled in an AWC for supplementary food, receiving micronutrient supplementation like iron and folic acid, calcium and other vitamins and minerals, or being weighed during pregnancy. Coverage is different from uptake, where the latter included papers that measure the actual consumption of supplements provided and changes in nutritional and feeding practices
based on advice received from FLWs. A few indicators used by included papers to measure uptake are utilization of services by pregnant and lactating women registered with AWCs, attendance at village health and nutrition days, and attendance of enrolled children at AWCs. For FLW level outcomes, compliance and knowledge are the most studied outcomes. Little attention is paid to other important factors affecting FLW performance, like quality of engagement, motivation, and time use. At the program level, we looked at 5 implementation outcomes, namely program adequacy, program access, program targeting, program monitoring, and program cost. We find that adequacy of resources is the most studied among the 5, with cost a remote second. Though it may be seen as worrisome as to how little attention is paid to the other outcomes under this category, it is important to note that adequacy of resources remains an important precondition for how the program performs with regard to other indicators, and therefore is a very important piece of information from the program implementation perspective.
This table summarizes information from the earlier slide. Significant gaps in literature are highlighted in red here. So we can see that there is almost no evidence available on delayed cord clamping or management of severe acute malnutrition, and fortification remains understudied. In a country where malnourishment is rampant and which bears over 30% of the global burden of severe acute malnutrition, these figures are troubling. However, for implementation research to contribute to the design of efficient programs and facilitate evidence-informed decision-making, it needs to focus on more than just filling the evidence gaps outlined in the earlier slides. For a large body of literature included in the study, the primary objective is not to study the program implementation. The studies do not systematically capture relevant information through the program causal chain, thereby providing limited insights on factors affecting program implementation. There is a preference to study those implementation outcomes that are easy to measure and are often tracked as a part of regular monitoring and evaluation of project progress. For instance, out of the 17 outcomes studied, participant uptake, participant coverage, FLW and health worker compliance, and FLW and health worker knowledge, and adequacy of program resources are the 5 most studied outcomes. We coded for barriers and facilitators, which are critical in explaining the failure or success of program implementation. At the outset, we would like to clarify that we had to code barriers and facilitators to implementation only for implementation outcomes that were measured in the included papers. Barriers to implementation were discussed more frequently than facilitators. In total, barriers and facilitators are measured in about 150 instances, which constitutes a mere 10% of the total number of implementation outcomes that are measured. We conclude this presentation by suggesting priorities for future research based on the findings of this study. National and state governments alike should develop high-priority implementation research questions. This would entail closing gaps in under-researched topics, such as fortification, weighing during pregnancy, and delayed cord clamping, and generating context-relevant evidence in underserved states. Given the limited attempts to understand whether implementation outcomes vary by demographics of the targeted group, these gaps in coverage equity need to be better studied. The literature also provides limited insights on factors affecting implementation. There appears to be a clear preference for studying implementation outcomes that are easy to measure and can be tracked as a part of regular program monitoring, like coverage and uptake. There needs to be focus instead on attempting to study the full spectrum of implementation outcomes that have a bearing on program implementation. There is an urgent need to remedy these issues and produce high-quality implementation research. Using these gaps in implementation research, we must try and identify appropriate areas of future implementation research and funding. Last but not the least, we must create adequate mechanisms to ensure that governmental and non-governmental program implementers use available implementation research and that strong linkages are created between implementers and researchers to support topically and geographically relevant implementation research. This is a snapshot of the implementation research gap map that we developed based on this study. We share the link through which it can be accessed. We hope that you will go through the implementation research gap map and working paper and reach out to us with feedback. Thank you very much for your time.